Well, hello, everybody, and thank you for joining us for today's session. And I am very excited to say that we have a wonderful guest here on the show with us today called Dr. Dawn Lemanne. And I hope I've said that correctly, have I?
That's correct.
Dr. Lemanne is here with us. She's an MD, and she is an author and a physician. And I'm going to read off her bio right in front of me because it's quite an extensive bio, but I don't want you to miss any of this wonderful information here. Her Ashland, Oregon Cancer Clinic draws patients from around the globe. Stanford trained in conventional medical oncology and a recognized authority on integrative medicine, Dr. Lemanne is one of a small but growing number of oncologists dedicated to integrating conventional and complementary cancer therapies. Dr. Lemanne is a proponent of rigorous single-subject research design development and is active in the quantified self movement. She was the first medical oncologist appointed to the faculty of New York's Memorial Sloan Kettering Cancer Center's Integrative Medicine Service and currently teaches physicians in the University of Arizona's flagship Integrative Medicine Fellowship. She is the author of peer-reviewed scientific articles, textbook chapters, and works for the popular press, most recently N of One, written with Glenn Sabin, who has also been on this show before, interviewed by Pat. Dr. Lemanne speaks by invitation domestically and internationally. Learn more about Dr. Lemanne's work at, and this is her website, so it is www.oregonio.com. So that is Oregon as in O-R-E-G-O-N and then I-O for Integrative Oncology, I assume, .com. And we'll repeat that at the end of the show. So for you folks who want to get in touch with Dr. Lemanne, we'll definitely mention that again. So that was a very extensive bio, and I'm very, very privileged and honored to have you on the show. And thank you for dedicating your most valuable time to being on the show and chatting to us and to everyone who's listening. So why don't I start off by saying, first of all, you started off being a conventionally trained physician, and then you moved into the integrative field pretty much so, and also into integrative oncology. What got you going to make that change?
Sure. Well, thank you, Kristen, for having me on your podcast. And actually, I have always been interested in cancer. When I was 7 years old, I wanted to be a doctor, and I knew I wanted to treat cancer patients. I didn't know the word oncology. But that was always an interest of mine. And I was interested in, even at that age, how diet and lifestyle impacted recovery from cancer, or even, the causes of cancer. And I'm old enough so that I remember when cigarettes were being newly vilified as possible causes of lung cancer. And that was a big deal. And people at that time didn't think much about diet at all. That was not something that was on everybody's radar as a cause of cancer. There was radiation, there was cigarettes, there were a few chemicals that we knew about, and then there was heredity. Those were the causes of cancer in the days that I grew up. So I grew up thinking I want very much to put together things that people can do at home, as well as things that doctors can do in hospitals and cancer centers to help people get well. So that was, I've always been interested in putting those things together or integrating them.
That's so fascinating to hear because, we have so many oncologists out there where we just wish they would actually just have a fraction of this kind of mindset, understanding that there is a relationship and that it really is also in the patient's interest to become an advocate for themselves, and that they can do something, that they don't just need to be passive recipients, but they can actually become actively involved. And
I think that oncologists are starting to move in that direction. The cardiologists are a little bit ahead of us. In cardiology, if you have, a heart attack, the doctor will prescribe medications, maybe even an operation, but they will also prescribe diet, exercise, stress reduction as part of the treatment. And we oncologists are a little bit behind in there. And the research isn't even there yet because we are just starting to think in those kinds of ways. So we're starting to do the kinds of research that we need to back up recommendations for diet and exercise lifestyle
Yes.
changes in cancer. And
Yes.
yes, I agree. I think patients really, if I could say one thing to patients, I would say, you know, don't think that what you can do at home is really a drop in the bucket. It's really a major part.
Mm.
You do need to see an oncologist and get whatever treatment makes sense to you in terms, and to your oncologist, work together with them in terms of trying to overcome the cancer. But don't put down the things that you can do at home. They're very, very powerful. Diet is powerful. Exercise is powerful. Sleep is powerful. Um, those things make a difference. And you need every bit of help you can get when you're facing something so life-threatening as cancer.
So how do you work with your patients? So if someone is, do they come to you after they've been diagnosed, or do they come to you when they're not feeling well and you are part of who diagnoses them? How does that work?
Almost always patients come to me after they've been diagnosed with cancer. So a biopsy's been done, a blood test has been done, something's been done that gives them the diagnosis of cancer. And then it's my job to help them put together a treatment plan. Perhaps they've already seen a surgeon. If they've had breast cancer, often they will have had a biopsy. One of the things that I want patients to know is that the surgeon doesn't actually make the diagnosis. The person that makes the diagnosis is a doctor called a pathologist, someone you will never meet. And it's really important to make sure that, as you would in any stage of cancer diagnosis and treatment, to get a second surgical opinion, get a second pathology opinion. And that, I think that step is often, just not in the ken of a lot of patients. It's not part of, they've never met the pathologist. They don't really have a feel for what happens to that biopsy specimen after the surgeon removes it and sends it off somewhere for a diagnosis. But a certain percentage of cancer diagnoses are changed with the second opinion. Sometimes the cancer diagnosis is erased. The second opinion physician feels that the cancer is not a cancer.
Wow.
That would be
Okay.
important to know. And that's not extremely often, but it does happen.
Yeah.
And even if it's only 3 to 5%, and I can't recall the statistics given by the American Cancer Society right now, and the Susan B. Komen site has some statistics on this too, but there's a certain percentage that are actually not cancer, or that are changed to a different type of cancer, which is important because different types of even one particular area of cancer, for instance, breast cancer, require different treatments, completely different treatments. So if you get the treatment for the wrong type of breast cancer that you have, you're not going to get the benefit, and you will get the side effects. So you definitely want to make sure that you get those second opinions. So there's a surgeon, there's a pathologist. About that time, that's when I will see the patient. And I'll help them put together a plan of treatment that may involve surgery, medications, which have a horrible name, chemotherapy. I think cancer medicine has a political problem in that we need to change the name of our drugs from chemotherapy to just medicines. All medications, actually antibiotics, high blood pressure medications, they're all chemotherapy in that they're made from chemicals. So
you're so right. I've never heard of it.
Such a PR problem there. So radiation may be part of it. Some other specialized treatments, for instance, interventional radiology, where an ablation is done for a liver tumor or something like that. So typically the medical oncologist is the hub of all of those treatment decisions, but we certainly work with all of the specialties involved in cancer care. But yes, to answer your first question, I will see the patient after they're diagnosed.
Okay. And
sometimes I will see a patient with, excuse me, but sometimes I will see a worried well patient. My mother's had cancer, my everybody in my family's had cancer. What should I do to lower my risk or catch it early, and those kinds of things. So once in a while I see those patients too.
You have that too. Before I forget, I just wanted to pick up on what you said about the second opinion. So I mean, I think getting a second opinion is at least becoming pretty standard, but do you recommend then that you specifically ask for a second pathological opinion too? Or is that when you say I'm having a second opinion, I'm going to a different surgeon, will it also involve a different pathological evaluation?
You have to ask. Usually it will not unless you ask for that. So you definitely want to ask for a second pathologic opinion as well. And another thing I want to say about second opinions is you want to go somewhere else for your second opinion, as far away as you can. Definitely don't go, in my opinion, it would be a mistake to go to another doctor in the same group, in the same practice, because they likely will have the same basic opinion. Or if they don't, if you see a less powerful physician politically in that group, they may be under pressure. And I think physicians resist these kinds of pressures, but I do want to say that they're there. They may be under, pressure to not go against something that maybe their boss has recommended to you. So you want to go at least across town, across the state is better, out of state is best, in my opinion, if you can afford it and if your insurance will bear it. Go as far away as you can to get your second opinion.
That's very valuable information. Thank you. Yes, I agree. It seems often though, it seems such an overwhelming thing to do. And when I counsel my clients, those that come to me that are just diagnosed and are in this very confused state, what do I do? Where do I go? It seems, I always, very gently approach the subject and say, you have the time to take to find someone, and just, go through the process again, submit the documentation again. It's very worth your time to actually go and do that.
There's something that I want to say about that, and that's that everybody in such a time as this is in very big overwhelm, and you need help. You need a person who can help you, a friend, a family member. Your family doctor might be that kind of an advocate. And the other thing I want to say is, whenever you see a doctor, especially if you have a serious illness, get every single medical record, and not just the my chart part of things, which can sometimes be, documentation light, LITE. It may not have everything on it, but what you want are the doctor's written records of their opinion of your visit. And it'll be written in prose, and it'll say things like, I think this patient should have this operation or that medication, et cetera, et cetera. Here's my physical exam findings, and here's who I'm sending them to. Those are the notes you want. You don't want this kind of spew that has one particular lab on every page, on a page, and then a whole, your address 20 times or something like that. That's not really, you should get those, but those aren't what I'm talking about. You really want the doctor's notes, and those aren't always easily available, but they're yours. You can ask for them and get them. Keep those in a file at your house, and when you want to go see another doctor, you can just fax those records to them. You don't have to ask your first doctor to send the records and wait while that happens.
Yeah.
That's really important. And I think probably your audience is really savvy about these kinds of things. But I meet patients who don't do that. And it really
many don't do
would
that.
save them a lot of time and heartache, I think, to just be able to quickly get their information to any doctor that they want to see.
Yes,
So,
no, I think many are, especially when you're thrown into this, you're still in this mindset that, the doctor knows best, and you kind of don't make that association that you, even in a situation like this, you are still your own advocate, and you still need to gather all your facts and figures together and understand that this is important. An important part of your whole treatment of your process is that you have access to these documents. So
it's really important.
Yeah, very important advice. Thank you. So to get back to your flow then, so you see patients that come to you that have been diagnosed, and are you able to offer the treatment in your clinic here in Ashland in Oregon?
Yes, I do treat some patients myself. I don't take insurance, so it does not often work out for patients who want to come and see me to also be treated by me. So I recommend that they also keep a relationship with another oncologist who does take their insurance. So if you're treated by me, I will treat you at a local hospital, which has a very nice outpatient oncology infusion center. And the reason that I do that, and that I don't treat patients actually in my clinic and take insurance for that, is that I feel that there can be somewhat of a conflict of interest there. It is, if that's the way that I make money, it's going to be, I'm just human, and it's going to be a temptation to me or to any doctor. I mean, not that I'm evil or anything like that, but to any doctor to perhaps just subliminally want to give more treatment than is absolutely warranted in that case. And I'm not saying that, maybe every other oncologist on earth has no thoughts of that, but I do notice that there's a push when you're making your money from a particular direction to want to go in that direction. So my patients pay me for my time, period, and that's it. You pay me an hourly fee. And but I do treat some patients. I pick very carefully the patients that I want to treat, because it's often better for a patient to go back home and be treated near home, and I can consult and help in that way.
Do you
Does that
consult?
answer your question?
Yes, yes, it does. Thank you.
Okay.
Do you consult virtually as well, or do you only
I
see
do.
people in
I
person?
do. So
Okay.
to consult with me by telephone is fine. In that case, we don't have I call it an informational consultation, and we don't develop we don't end up with a doctor-patient relationship. In other words, if I make some recommendations based on our conversation, and I may have reviewed your records and things like that, but I would ask then that you definitely go and confirm any tests that I recommend or any directions that I recommend you take with your treating oncologist. Make sure that they, who have also examined you, go along with the recommendations before you carry them out. So because I can't examine a patient virtually yet, although I think that day is coming soon, that does not give us the same kind of doctor-patient relationship. But once you've seen me in my clinic, and I've examined you, and we've developed and have established a mutual relationship, a doctor-patient relationship, then yes, I can order tests, blood tests, make some recommendations over the phone, just like your local doctor could, within certain parameters. I mean,
Sure.
So
Do
I have
you?
licenses in California, New York, and Oregon, so I can order tests and things in any of those 3 states.
So I'm assuming you're also referring to certain functional tests. Do you use those, like the OncoBlood test, for example?
I don't use the OncoBlot test. I'm interested in it, and I think it still needs work. So the few patients that I've had who've had OncoBlot tests that I haven't ordered, 3 of them recently have been somewhat off in ways that were very important.
Okay.
So, I don't want to bash OncoBlot. I'm not bashing it at all. I think it's really interesting and important work. I think, I say to the OncoBlot people working very hard on that, keep going. Keep going.
Okay.
Let's perfect these kinds of tests. Not quite ready yet to base any serious information or action on.
And let me just recap for the viewership what the OncoBlood test is very briefly. It's just it's a blood test based on trying to see if there are so-called circulating tumor cells, which is something that can be detected much sooner before there is even any degree of tumor formation. So it's a good way of also maintenance, like in my case, for example. And I have been toying, I'll share that, I've been toying with the idea of should I do this or not, because that's another thing where I wanted to ask you, how do you do with the follow-up? Do cancer survivors who have finished their conventional treatments and basically have received the green light from the conventional oncologist who then says, I'll see you in 6 months or a year, when you're at that stage, do you then help patients have a maintenance plan going forward to kind of keep an eye on things? And I'm asking this specifically because if you stay with just your traditional oncology team, and in my case, I've had a bilateral mastectomy, so the breast tissue is removed. So the answer I got, for example, is we'll do a couple of blood tests, but tell us how you're feeling. We don't recommend regular PET or CAT scans for obvious reasons. But other than that, they didn't offer me anything else to look inside my body and see, well, what's happening. And my whole thing was, by the time I feel something, if there is another tumor somewhere else in the body, it's way more advanced than my actual initial breast cancers ever were. So I felt a little bit left in the dark from a point of view of just diagnostically, what can we do to kind of keep you on track? So do you help survivors in that field as well in your clinic?
Absolutely. And there are two issues that come up with this particular scenario. What do you do after the cancer diagnosis and after the treatment is over? And this is a point where patients often feel the bottom drop out while they're busy with treatment and everything. You're working, you feel like you're pushing back against this event that has happened to you. But once that's all done, what do you do? Just wait to see if something bad happens? And that's untenable. And this is one point where I really think patients want to be very, very proactive. It's very important that you feel that you're in charge. That actually changes your internal metabolism and hormonal milieu in beneficial ways. But anyway, there are 2 things that doctors are dealing with when they're looking at a patient and trying to figure out, what should I do now that the cancer has been treated and we're just going to watch this patient. So there's a philosophical issue that doctors run up against, and that is doctors don't want too much data. And that's because if you collect data, and this is purely a habit, and it can be changed, but if you collect data but you don't know what to do with it, you're kind of in trouble. And there are legal issues. Can the patient come back and say, well, later, well, you collected this data, it turned out to be pointing in some direction, you didn't take action, so I'm going to sue you. So there are those issues for doctors. Or, and the second issue is Western or conventional medicine doesn't look at cancer as in a holistic way.
Yeah.
It doesn't look at the precursors, the whatever happens during it. It doesn't look at what happens afterward. It only looks at removing cancer cells. That is the whole paradigm of conventional cancer treatment. How can we remove these cancer cells? Now that's important, I think, in most cancers, not all of them, but in most cancers, it's important to remove the cancer cells, and then beyond that, and I think what your group is working on and pointing out so beautifully is that you have to fix the problem that led to the ability of those cancer cells to accumulate in the first place.
Yeah.
We in Western conventional medicine honestly don't know a whole lot about that. We're starting to look at metabolism, glucose metabolism. There are other things besides glucose. We hear that glucose feeds cancer. There are other things. Certain fatty acids will feed certain cancers with certain mutations, just as glucose does. Certain amino acids, proteins, can do the same thing. So there's a lot we don't know about that. But patients are starting to say, well, look, can't we follow my general health? And here are some new tests to do that. And I think they are getting frustrated that they're not finding that in the oncologist's office in general. So in my office, one of the things that I have a lot of my patients do is follow their glucose levels. Even if they're not diabetic, I have them buy the little, they're less than $20, the glucose monitors that you prick your finger at home and it gives you a reading from your blood. I like them to try to work with their diet and with some intermittent fasting to get the glucose levels down into the optimal range, not just the non-diabetic range, which is less than 100, but I like it in the optimal range, which I think is between 75 and 83 in the morning before you eat anything. I like it to be 120 or less after meals, 60 minutes after meals. So we work on those kinds of things. For some patients, I will recommend some intermittent fasting. I recommend that all my patients go on a 13-hour overnight fast. So when you put your fork down at 6 p.m., not when you start dinner, but when you put your fork down from that evening meal, say at 6 p.m., that means no calories until 7 a.m. the next day. And there was an interesting study published in JAMA, the Journal of the American Medical Association. This is not an alternative journal or organization by any means.
No,
a few months ago, that published a nice observational study of women who did this after a breast cancer diagnosis, and women who had a 13-hour or more fast over every night did much better in terms of breast cancer recurrence over the 2 or 3 years of the study. I forget the exact length that they observed these women, than women who had a 12-hour or less fast. So the difference is between 12 hours and 13 hours. So I like to tell my patients, don't mix up and come back and say, oh, I'm doing the 12-hour fast every night that you recommended. No, it's 13 hours. The 12 hours was kind of the control groupings, which the improvement was measured. So things like that, watching the glucose, fasting. Sometimes I put patients on a ketogenic diet. That's a whole different topic. Sometimes I put them on a raw vegan diet. And usually these diets are temporary. We're trying to adjust something. They're not a lifelong measure. Usually a patient will have to fiddle around with their diet to get the perfect diet that they want to carry on for a long time. And they may have to change that. It may change.
I totally agree with that. I totally agree with that.
Seasons, it may change during different parts of your life. So.
Oh yes, absolutely. There is no one specific single cancer diet, and we have to be very mindful of what works for you and when. As you say, the seasons play a role too. Yes, it's a constant motion. I just had a conversation with actually a friend of mine in Germany who knows someone who's going through cancer, and her thing was, I didn't realize it's going to take the whole year. And it's like, going to take you a lifetime now of adjusting, of looking out, becoming conscious, and looking inside your body and being mindful. You become, just stress, the effects that stress can have physically. In my own journey, I've realized that certain stressful situations, even though I think I can handle them because I know stress management tools, I will have physical effects after that, and I can always lead it back to, obviously I check my bases, but I can often lead it back to it's as a result of that particular stressful situation, whatever it was, family crisis or something else. And those are the things we have to become, I think, mindful as survivors. Is we need to learn to listen to our bodies and to make the connections. If something's happening here or there, or if we had this 3-month tremendous period of either stress at work or the dog was dying or something like that, it can have a physical impact on you. Again, change your glucose levels, maybe. Just become mindful of that,
Yes, I completely agree. And I'm really glad to hear you say that. I think that, most people know that stress is bad. And we're talking about long-term chronic stress, not the intermittent stress of, doing an interview or a podcast or something like that. Those are, those are good things. You're supposed to have some, little bumps in the road. You don't want cancer and disease in general likes to have something really predictable. So one of the things you want to do is mix it up. But if you're constantly under tremendous stress, that's going to be very detrimental to your health. And so I completely agree. And one thing, go ahead.
No, you go ahead.
Well, one thing that I really think is important is that if you don't feel, you don't have to love your doctor, but you should feel that they're on your side, that they have a friendly attitude toward you, and you should trust them. And I find a lot of times I will see a patient who will come in and say, well, I want a second opinion. And I'll look at the first, what the first doctor has recommended, and there's nothing wrong with it. It's great. And I'll say, well, this looks pretty good. This looks like a good treatment plan. What is holding you back? And it will be their relationship with the doctor. They don't quite trust the doctor. It wasn't even the information. It was really the caring connection. And that connection, that doctor-patient relationship is part of the medicine. If you feel better in the presence of your doctor, pay attention to that. If you feel worse in the presence of your doctor, pay attention to that. Get out of there. Get a new doctor. And stress,
so true.
You don't want to have the doctor-patient relationship adding to the stress of that diagnosis. It should be a moment of a kind of an oasis, like, oh, I'm finally in some place of safety where this person is going to help me. So if you're not feeling that, that's a danger sign. And maybe you can fix that. You might be able to say to that doctor, I'm just not trusting this particular 1, 2, 3 about what you said, or, I don't like it that you're not helping me pay attention to my diet. Can we work on that? Or whatever it is that you think might, respectfully, but really in a real relationship sort of way, help your doctor and you get on a good track that you can just relax and trust it. I think that's important to pursue that. And if you can't make it work, then it's important to get out of there and
to change. I agree. I always say to my clients that you are hiring the doctor, not the other way around.
Well, see, that's not true. The insurance company is hiring the doctor.
Well,
these days.
I mean, in terms of you select the person, right?
Yeah. But they don't work for you. That's why I think that the insurance system, I'm going to get a little political here. I'm going to say that, the insurance system has set things up so that the patients are so out of control. They're not in control. The doctor really doesn't work for you if they're taking your insurance. The doctor has to work for the insurance company. They have to do what the insurance company says. So just be mindful of that. I mean, we have to work most of us have to work within the insurance system right now.
Yes.
Do be mindful that they have a divided loyalty and they're not working for you. And if you fire them, it's no skin off their teeth. Usually there's so many patients in line, they'll just take the next one in.
It's true.
So it's tough right now for patients. It really is.
Yeah. Do you ever find in your work, because you say, you prefer your patients to still be in touch with their conventional oncologist, do you find that that there's any animosity there between, on a professional level now, between you and the oncologist, or are you always able to work well with each other?
With the good ones, I'm going to say it this way. I'm going to say with the good ones, the ones that, all of us have ego involved in this, and the ones that can put that aside and just get the work done and take care of the patient, they're a joy to work with, and that's most of them. There are a few pills who, say my way or the highway, and will
Mm.
fire a patient for not taking a particular recommendation. I think that's wrong if the patient is respectful and just trying to have an open dialogue with their doctor. Um, but I would say that, the really good oncologists, which are most of them want to do a good job, are grateful for some outside input that will help the patient, take the treatment that they're often recommending correctly, and get on with getting well. So most doctors are okay with it, not all.
Okay. Yeah, I find the same thing.
Yeah.
So, some are very willing to look at my little protocols and so on, and others just completely dismiss it. And yeah. Anyway, so in order for patients to find you, how do they approach you? Is there a long waiting line? Do you work every day of the week? Do you want to tell us a little bit about your clinic and how patients could get in touch with you?
It's very easy to get in touch with me. You can call me. My phone number, the office, is 541-488-6261. And if I'm sitting by the phone, I pick up the phone myself. And I work in an office with a surgeon and with an internist and with a neurologist, and a metabolic rehabilitation MD. So there are other doctors around, but there are no other oncologists in my office. And so I'm available most days of the week by appointment, and it's very easy to get in touch with me. And I hate phone trees, so I've decided to be very different that way. I just literally answer the phone, and if you're my patient, I give you my cell phone number so you can call me if you're having a problem.
Wow.
And I've not had, I've rarely had anybody abuse that. I would say it's never happened, but one of the most amusing was I got a call at 3 a.m. Oh, and I could hear loud music in the background, and the patient was saying, "Oh, Dr. Lemanne, that injection you gave me, I feel so much better. I'm at a party."
Wow.
I just wanted you to know how good I feel today. So, but anyway, my patients are very respectful, and I think patients become frustrated and angry and make it difficult for other people to deal with them only when they have felt that from the system, when they can't get through, when they can't get a call returned, when they can't get their results, when they can't get in to see the doctor, or if they can't get their questions answered. That's when things go sour in those relationships. So
yes, and the communication, absolutely. Not being called back on and things like that, having to chase after people. I agree. Okay, so they cannot expect that from me. That sounds awesome.
So yeah.
Okay.
It's been working.
So your website again was www.oregonio.com. Is that correct? You want to repeat
correct. That? It's OregonIO.
Okay.
For integrative-oncology.com.
Okay.
And, yeah.
So in conclusion, and thank you so much, we're very humbled to have you here and be so, speak so openly about your experiences. But I think it's so important to, this is empowering information for many patients out there that are looking, what else can I do? Because many understand that I have to go the conventional route. I don't want to go alternative. And I'd actually like to have a quick view from you on that as well. So they understand I need to do a combination work, a complementary work, but who do I trust? How can I fit this in? So I think it's, the work that you do is so vitally important to, again, guide the patient to make very informed decisions and become their own advocate, become more empowered in this cancer journey, not feel such a victim. So just as my final question to you, so if somebody comes to you and says, I do not want to go the conventional route, I want to try alternative, what's your general advice if there is such thing?
Happens all the time. Patients will come in and say, even when I was at Sloan Kettering, patients would come in and say, well, I don't want what they're giving across the hall. I want, herbs and vitamins and things like that. And a lot of times what we can do is find out what the patient is afraid of. A lot of times the patient will be afraid for good reason of the side effects of a particular drug or regimen. So one thing that I like to do is give what I call a test dose. I give a small dose of a particular drug and we see how the patient does. And then I can gradually, with the patient's permission, over a period of several weeks or whatever schedule makes sense with that patient, increase the dose until we're at or near the conventional dose, and the patient has complete control. They can say, you know, I had a side effect that I'm just not willing to put up with that last dose. Let's stop there, or let's back up, or let's stop completely. So that's been a very powerful tool for a lot of patients when they have control over the spigot, and they're literally, you know, telling me, no, you can go up on that dose. I'm okay.
Okay.
That will often get a patient through, you know, what otherwise would be a very frightening and horribly disempowering moment in life.
Yes. Yes.
And still allow them to the benefits of, you know, what can be life-saving treatment. A lot of these treatments are really life-saving, and we really want to try to get these done if you can. The other thing is if the patient has, you know, will come in and say, absolutely not. I'm, you know, no matter what you say, I will never, ever, ever take any of these conventional treatments. I say, okay, let's measure how you're doing. You know, what do you want to do? And they'll say, well, I want to do, you know, special diet, or I want to take these herbs. You know, I want to do all of those things, put them together, and I'm working with the herbalist. Okay, so let's measure how you're doing. And we find something that works for them. It can be a blood tumor marker. It can be circulating tumor cells. It can be, you know, scans of some sort, ultrasounds, MRIs, CT scans, whatever, whatever seems to make sense. And we follow. Are you getting better?
Yeah.
And if you're not getting better over a certain period, and we make a plan. You know, after a month, if you're not getting better, what do you want to do? You want to keep going? You want to try something else? You know, so we have a real outline of what's going on. If a patient has a cancer that's curable with conventional treatments, I try very hard to get them onto that conventional treatment. If they have a cancer that's not curable, that conventional medicine says we can't cure this, for instance, things like glioblastoma or advanced metastatic pancreatic cancer, those are things that conventional medicine typically throws up its hands or says, we'll go into this trial over here in, you know, some other state, and we'll see if we can do something. Those are different cases, and in those cases, you know, we do the best we can and just make it work for that patient. What does that patient want? And the patients will come in, they're not, you know, outside of reality. They say, you know, I'm probably, you know, I might die of this. I probably am going to die of this, but I really don't want to take these other treatments. Can you help me? And we'll figure out something we can do that makes sense for them.
Yeah. Yeah, that sounds awesome, because again, it puts the patient in the driving seat, that they feel they have a little bit of control.
The patient needs to be the driver. The patient needs to be in control. And I think, you know, that's, if we do one thing, if I do one thing in my lifetime, if I can help patients get back into the driver's seat in medicine, whether it's by insurance reform or insurance disappearance, or, you know, and having medicine be, you know, a normally priced item, not this tremendously artificially inflated object that nobody can afford. You know, and if there are other ways that I can put patients back into the driver's seat, I've completed my life's work.
What wonderful concluding words. Thank you so much. That makes so much sense. And again, let's just, for the viewership, just repeat how we can get hold of you. Would you just like to quickly repeat your telephone number again?
Sure. You can call me at 541-488-6261, or you can go to my website, and that is OregonIO.com. And on the website are email addresses and more phone numbers, and you can call me.
Great.
During business hours.
Yes, not at 3 a.m.
Pacific time.
Good. Thank you so much.
You're welcome.
I'm going to end the recording now. So thank you so much. It was a privilege and an honor to have you on the show.
My pleasure. Thank you, Kristen.